Good evening, ladies and gentlemen. Welcome to this ERS webinar on congenital airway diseases. To me, this is a special webinar, as actually it was my co-chair, Carolina Cotera, who suggested this webinar. And this is special because Carolina is a respiratory physician caring for adults. She's based in Madrid, in Spain. And congenital airway diseases may seem a pediatric problem, but more and more physicians for adults are caring for patients with these diseases. And therefore, I'm really very happy that today we will start with a presentation from a pediatrician, move on with a respiratory physician for adults, and end up with a lung surgeon who made the step from adult surgery to pediatric lung surgery. If you have any questions, please post your questions in the chat, and we will come back to these questions at the end of the three presentations. And I'm really happy to hand over to my co-chair, Carolina Cotera, who will introduce the first speaker. I don't hear Carolina. Well, maybe I will introduce the first speaker then. And the first speaker is a very well-known pediatric pulmonologist, Professor Ernst Eber. Ernst is professor of pediatrics and is chairing the Department of Pediatrics and Adolescent Medicine in Graz in Austria. Ernst has been very active in ERS and is still very active within the ERS. He's one of the founders of the ERS Summer School. And he will start this webinar with a pediatric perspective on congenital airway diseases. Please, Ernst, go ahead.
Thank you very much, Marielle. I hope I can be heard. And what I'd like to... Okay. So what I would like to give here is a very short, very brief introduction to congenital airway diseases. I do not have any conflicts of interest with regard to this presentation, and these are my aims. As I told you already, it will be a very brief overview, and I'll talk about some of the basic concepts and also the diagnostic approaches in the context of the main congenital airway malformations or airway diseases. This is a table from the new edition of the ERS handbook that will come out in a few days or weeks at the latest, and shows you some of the important congenital airway malformations. And you see the order here: nasopharyngeal airway, the larynx, and the trachea, and the bronchial tree. And obviously within the next 14 or 15 minutes, I will not be able to go all through these pathologies. I just want to pick out the one or the other as an example. So if we start off with the nasopharyngeal airway, you all know there will be a possibility with a newborn with choanal atresia or stenosis. And what is very important here is that 2/3 of these children do have associated anomalies. And this is what I want to point out here. Whenever a child has a congenital airway malformation, there's a huge chance that there are associated anomalies. And what is also clear here is that depending on the type and the location and also the degree of the airway obstruction that is caused by the airway malformations, you may have different signs or symptoms or consequences. And in this case, this may, with bilateral atresia, lead from respiratory distress at birth. And if you only have got a mild and unilateral lesion, this may be only detected later in childhood with chronic rhinorrhea or whatever. Diagnosis is very often done by airway endoscopy. Very often it's flexible airway endoscopy, but sometimes also rigid or a combined procedure, and some kind of radiology here for this kind of pathology is the CT scan. This is an example showing you a normal situation on the left side and a situation of bilateral choanal atresia post-surgery. Obviously, you see that the round holes here, still after surgery, smaller than the normal choanae are. Just an example of flexible airway endoscopy here, an example for CT scanning. You see on the left-hand side the normal situation again. On the right-hand picture, you see a unilateral choanal atresia. Actually, it's an osteomembranous choanal atresia. So there is a bony pathology and also a membrane that is pointed out here by the arrows. When we move a little bit further down to the larynx, then obviously we have to talk a little bit about the main symptom here, or the main sign, which is stridor. It's very often the most prominent symptom of upper airway obstruction, and it's clearly indicative of substantial narrowing or obstruction of the larynx and the extrathoracic trachea. And it's very important here to point out that patients with more than 50% of obstruction may be asymptomatic. So if you look at this classification by Meyer and colleagues, grading from 1 to 4 of airway obstruction, you see that grade 2 is defined as 51 to 70% of obstruction. It's only here that stridor develops. So you will not usually have stridor in a child with grade 1 airway obstruction. And this is why stridor is also visible. This is a term that has been coined by Bob Wood, one of the pioneers of flexible bronchoscopy. What did he want to say by that? If there is stridor during the investigation, if you do flexible airway endoscopy while the child is stridorless, you will have to see, the bronchoscopies must see what the pathology really is here, because you will never have stridor with only very mild degrees of airway obstruction. And laryngomalacia actually is the most common congenital laryngeal anomaly and also the most common cause of persistent stridor in infancy. Not the only one, but the most common cause here. And again, if you look at children with laryngomalacia, you will see that frequently they have associated other airway lesions, and also there is a strong association with gastroesophageal reflux here. I don't want to go into all the details here of this slide, but what's very important again is that you always need in medicine history and physical examination, and this has to be done thoroughly here, but still, again, you need some confirmation by flexible airway endoscopy if the stridor is not only very mild and there is no other pathology with the child. This shows you an example of one of the many classifications around, and this is actually has been put forward by the group from Groningen in the Netherlands, and you see here 3 types. There are other classifications with 5 types. All of them describe more or less the same. I don't want and cannot go into detail here, but as you can see, it's many different types of laryngomalacia. But if you look at children with persistent stridor, there are many more pathologies as a differential diagnosis. If you look at the first line and then the second line, always from left to the right, you will see a cyst at the base of the tongue, a cyst in the larynx originating from the left false cord. There is a partial glottic web, left vocal cord paralysis, and in the second line on the left, it's a posterior cleft of the larynx, subglottic hemangioma, and different forms of congenital and acquired subglottic stenosis. So a wide range of differential diagnosis to laryngomalacia in a child with persistent stridor. Moving down a little bit further down to the trachea, tracheoesophageal fistula with esophageal atresia. It comes with an incidence of 1 in 3 to 4,000. And again, I want to point out here that more than, or at least half of the children will have associated anomalies in the upper or lower airways, or in the cardiovascular system and other systems. And many of you will be familiar with the FATRA and FACTO associations. And again, very important here that there is not only pathology in the esophagus, obviously, and with the fistula, but there in more than 50% of these children do have structural anomalies of the tracheal wall, and this is termed tracheomalacia. The so-called H-type tracheoesophageal fistula, which is the isolated tracheoesophageal fistula without esophageal atresia, is much rarer. You see the incidence here, 1 in 80 to 90 or maybe 100,000. This type is not commonly associated with other anomalies, and it's usually located in the extrathoracic, so in the proximal third of the trachea. Again, diagnosis established by flexible and rigid airway endoscopy, and maybe also done by contrast injection. Establishment of the diagnosis can be quite difficult in these children because the fistula are usually very tiny, very small. So if you look at the tracheas of children with tracheoesophageal fistula, and this is a very nice paper, they looked at 40 tracheas from children, and they found only 6 of those entirely normal. So the vast majority had deficiency of cartilage, and in only 9 patients, the abnormalities of the tracheal wall were restricted to the side of the fistula. So very often, there is a reduced circumference of the tracheal cartilage and a widened membranous part. In the left picture, you see that the usual ratio, which is 4 to 5 to 1 cartilage to membrane. And in the right picture, you see this widened membranous portion where the ratio is 2 to 3 to 1 maybe. This is what is seen very often in these children. Tracheal malacia, if you take all those together with or without other associated anomalies, come in an estimated incidence of 1 in 2,000 children. And there is certainly weakness of the airway wall, which is frequently due to reduction and or atrophy of the longitudinal elastic fibers of the pars membranacea or impaired cartilage integrity. There may also be abnormal cartilaginous matrix, so some kind of immaturity. And the other form, as I've already pointed out, with a reduced circumference of the tracheal cartilage. This renders the airway more susceptible to collapse, which leads to retention of secretions from the lower airways, and this in turn to bronchopulmonary infections. If you look at the signs and the symptoms of how children present with tracheal malacia or also with tracheobronchomalacia, you see almost everything here you can imagine when it comes to signs or symptoms of the respiratory tract. You see the list starts off with stridor, barking cough, respiratory distress, etc., failure to thrive, obviously breath holding spells, and even in the most severest forms, respiratory or even cardiac arrest. I've pointed this out already. You see again a schematic drawing here with this normal picture on the left-hand side and the widened membranous portion on the right-hand side. And the picture below shows you this impaired integrity of the cartilage. This is actually from a bronchus. And you can see here that there is cartilage. This is this light gray areas here, and they are interrupted by membranous material. If you want to classify airway malacia, there are different forms to do that. You can differentiate between congenital forms and acquired forms, obviously, between localized and generalized forms, and also primary and secondary forms. Meaning that in a secondary form, you have airway malacia, tracheal malacia in the case here, for instance, caused by compression, extrinsic compression. So different classifications again. This is an example for intrathoracic tracheal malacia, and as you can see clearly on the right-hand side picture, is that there's this collapse, this partial or subtotal collapse during expiration. And this can also be shown indirectly if you do lung function testing. If you do a maximal flow volume curve, which was done in this 7-year-old child, and you look at the expiratory limb of this flow volume curve, you will see a plateau in a child with tracheal malacia, with intrathoracic tracheal malacia. With extrathoracic tracheal malacia, you would see the plateau in the inspiratory limb of the flow volume curve. I've got a question for you as well here. This is an 8-year-old girl presenting with recurrent episodes of dyspnea, wheezing, cough, only in the course of viral infections. But she also lags behind in school sports. And the physician suspected bronchial asthma, but anti-asthma medication did not improve the situation. Physical examination was unremarkable. Lung function testing showed a plateau in the expiratory limb of the flow volume curve. And flexible airway endoscopy showed what you can see here. So there was some obstruction of the trachea in the right-sided and the posterior aspects. The question for you now is, what is the most likely diagnosis? Is this abnormal innominate artery, an abnormal right carotid artery, abnormal right subclavian artery, double aortic arch, or a pulmonary vascular sling? Please vote. Okay. So it's 42% of you voting for pulmonary vascular sling, and this is the correct answer. And the other 58% of you voted for either innominate artery, which would cause a compression of the anterior aspect of the trachea, or double aortic arch, which I will show you in a minute the typical picture of. So it's, I cannot, Okay, so pulmonary vascular sling is the right answer here. And I show you this slide again. If you look to the left picture in the line below, you can see the endoscopic view and also the corresponding MRI and the 3D post processing. And you can see here this left pulmonary artery originating from the right pulmonary artery and then crossing from right to the left. Behind the trachea and in front of the esophagus, causing this compression on the right and the posterior aspects of the trachea. What you can see in the first line is the typically endoscopic view of a double aortic arch with the compression usually in the anterior and the right-sided aspects of the trachea. So an experienced endoscopist can judge from the endoscopic view what kind of vascular anomaly is there if they see a pulsating compression of the trachea or one of the main stem bronchi. Bronchomalacia obviously is also possible in combination with or without tracheomalacia, and this shows you just two examples. On the left-hand side, you see what you would call a congenital lobar emphysema. Actually, this was a very huge hyperinflation of some aspects of the right lung, and this was caused by bronchomalacia of only one segmental bronchus. It was the segmental bronchus number 1, so the apical bronchus of the right upper lobe that had bronchomalacia. So what you can see here in terms of this hyperinflation, this was only 1 out of 10 segments of the right lung. What we usually do not do routinely is doing tracheal bronchography, but what you can see nicely here is that during inspiration, you see the normal caliber of the left main stem bronchus here, and during expiration, again, this collapse, just to show you that you can also have radiological investigations to prove that. But usually nowadays, it's done by flexible airway endoscopy. I will come to tracheal stenosis for a minute. Again, many different forms, many different locations and length actually, and also obviously many different degrees of severity. Again, these stenoses are frequently associated with other anomalies like pulmonary artery sling I just showed you before, or abnormal bronchial arborization, or even a single right or left lung. And this shows you from the group of the Great Ormond Street Hospital in London, their kind of classification or what they found in their series. And you can see virtually everything you can imagine in terms of combinations of congenital tracheal stenosis or congenital tracheobronchial stenosis with normal arborization or with or without the tracheal bronchus, trifurcation, single Young's, etc. So many different forms. This is just another example showing you a short segment stenosis only, depicted by the red arrow here at the level of the bifurcation. So very severe stenosis, the corresponding picture of the flexible bronchoscopy you can see on the left-hand side. And this child also had a parenchymal lung malformation in the right upper lobe, which turned out to be a congenital segmental emphysema, or the other name for it is bronchial atresia. Tracheal bronchus I mentioned, and I will finish off with this anomaly because this is a kind of a more frequent anomaly. It's seen in, at least according to 2 series, in 1 to 2% of bronchoscopies. What is it? It's either an ectopic or supernumerary lobar or segmental or subsegmental right upper lobe bronchus that arises from the lateral wall, and obviously it must be the right lateral wall if it goes to the right upper lobe of the trachea. If this bronchus is normal, then there is no problem really with it, unless there is intubation and the endotracheal tube bypasses the origin of the bronchus and causes a atelectasis then. But there are very often structural abnormalities like stenosis or malacia, and also stenosis of the distal trachea, which I showed you already before. Again, in many cases, in some series, up to 100% of cases, this anomaly is associated with other malformations. So again, if there is one malformation, you have to look for others in the respiratory tract or other organ systems. This is showing you an example of a tracheal bronchus, again, also the endoscopic view corresponding to radiology. And this is my last slide already. What I wanted to tell you is that airway anomalies may be part, and very often they have complex syndromes, and in many cases they are associated with other congenital anomalies. Mild to moderate stenosis in the first years of life frequently become less prominent with airway growth, and it very much depends on the type, the extent of the malformations, whether you choose a conservative or surgical management option, and this always has to be chosen on an individual basis. With adequate management nowadays in most patients, the long-term prognosis is favorable. Thank you for your attention.
Thank you to everyone. And I would like to introduce the next speaker, Marco Snader, who is General Thoracic and Pediatric Surgery. And we are so happy to you are being here with us. And please, wherever you want.
Well, thank you, Carolina. And let me start by thanking the ERS for this kind invitation, and of course to the chairs for giving me the opportunity to present something about congenital lung malformations. Of course, I also want to thank the audience for joining us here today. And as you can see, I'm working in the Pediatric Chest Center in Rotterdam. And this center is a center which focuses on anomalies and diseases in the thoracic cavity. And all involved specialties are working together as a whole, as an entire team. This makes the center unique in the Netherlands and maybe even in Europe. How can I go to the next slide? I have no disclosures. Next. And the aims of today are summarized on this slide. First of all, I will give you a very short overview of the different congenital lung malformations, followed by highlighting the current mondial debate. Finally, I hope to convince you that stratification of CPAM patients is a necessity, and of course, there will be some short take-home messages. To make this presentation a bit interactive, I've set up 2 slides with a multiple choice question as requested by the ERS. Let's start with an overview. The slide shows you a spectrum of congenital lung malformations we're talking about, and the most common one in order of prevalence are CPAM, or congenital pulmonary airway malformations, bronchopulmonary sequestration, congenital lobar overinflation or emphysema, and bronchogenic cysts. This presentation is mainly about CPAM, and CPAM is divided into 5 types depending on the site of the airway it originates from. Let me take you through the first case I would like to present to you. It's about a male, prenatally known with the right-sided CPAM type 1. He was born at 37 weeks with a birth weight of 3,000 grams, and postnatally had no respiratory distress and was discharged at day 1 after confirmation of a cystic malformation on an X-ray. At 6 months of age, the boy started to show mild tachypnea, intercostal retraction, and the chest CT showed a large CPAM type 1 of the right upper lobe with some air trapping in the lower lobe and a slight mediastinal shift. What would you do? Would you go for surgery, or would you follow a wait and see policy? Well, 72% of the audience would do surgery, and we performed surgery in the symptomatic patient as well. After selective, sorry, I will try to get the next slide. After selective single lumen tube intubation into the left main bronchus, an open lobectomy of the right upper lobe was performed. On the left panel, you can see the perioperative kystic appearance when opening the thoracic cavity. And postoperatively, there were no problems. The symptoms had disappeared and the boy was discharged after 4 days. The pathologist confirmed the CPAM type 1 with no mucinous proliferations, but with a KRAS mutation as shown. What would you do? Discharge the boys without any regular checkups, or would you see him at several time points again? The second case I would like to share with you is a male as well with a known left-sided CPAM on prenatal ultrasound, and the boy was born at 39 weeks. Birth weight was 3,800 grams, and postnatally he had no respiratory distress. The boy was discharged after an X-ray confirming CPAM, and at 6 months the boy was still asymptomatic, and the CT scan showing a CPAM type 2 combined with a bronchial atresia with hyperinflation of the entire left lower lobe. In the right panel, you see a volume measurement proving that the entire lower lobe was affected. So again, what would you do? Would you do surgery or would you follow a wait and see policy? Most of the people are voting for a wait and see policy. How can I close this? But so looking at these two cases, I would like you to remember that there still exists an ongoing mondial debate for CPAM about the asymptomatic patients. There is consensus to do surgery in symptomatic patients, but most patients are asymptomatic, and the treatment, surgical resection or not, depends on the center's preference. Another interesting debate exists about the possible malignant degeneration within this malformation. A large group of surgeons do resect all asymptomatic CPAMs because there might be a malignant degeneration in the future, although the incidence is very low. Other debates are still existing about resecting the whole lung or just the affected segments and the role of a possible compensatory lung growth. In other words, a lot of questions, but no real clear answers. In order to end these debates, we set ourselves the following overall aim. We want to stratify CPAM patients into a low and a high-risk group in need for surgical resection. So our line of research started with the standardization and optimization of diagnostics in CLM. So we did several imaging and pathological studies, and one of the interesting findings in this work was that 16 out of the 50 patients with a CPAM, both type 1 and both type 2, are KRAS positive. KRAS is a well-known lung tumor marker in adults, and if mutated would prove malignancy. In children, the role of KRAS in CPAM is not known, but we hypothesize that patients with KRAS positive CPAM belong to the high-risk group of patients and should therefore probably be resected. Furthermore, we started a large European Delphi study in order to define a core outcome set for future international CPAM studies and invited the European Connect and initiated the European Connect Consortium, in which 26 European partners are involved. Connect stands for Collaborative Neonatal Network of the first European CPAM trial, and the idea of the trial is to randomize asymptomatic CPAM patients into a surgical and a non-surgical group. The preliminary work for this trial is currently being performed, and we do think that the Connect trial will give us an answer about which children belong to the low or high risk group of patients according to clinical parameters. In other words, This trial can aid in the development of a prediction model for patients at risk for complication or adverse outcomes. The setup of this trial is currently run by a PhD, and if you are interested, you can ask for information at connect@erasmusmc.nl. Finally, our cell biological studies in KRAS positive and KRAS negative CPAM patients will aid in implementing individual patient care and in our goal to stratify CPAM patients into a low and high risk group in need for surgical resection. So let me finish with take-home messages. I hope that after my presentations, you know that there still exists a mondial debate about the best treatment strategy for asymptomatic CPAM patients, and that our goal or challenge in the near future should be to stratify these patients into a low and high risk group of patients in need for surgery. It appears that more and more data are showing that part of the patients carry a KRAS mutation, a valuable tumor marker in adults, but that the meaning of this finding in children is still unknown. Thank you for your attention, and back to Carolina and Marielle.
Thank you, Marco, for this very nice presentation. We move on with the third speaker of this evening, and it's my great pleasure to introduce Dr. Lieke Kamphuis. I have an echo, but I hope you can.
Lieke, please shut off the microphone until you have the right to speak.
Okay, let's try again. I'm sorry for this. It's a great pleasure for me to introduce Dr. Lieke Kamphuis. Lieke is a pulmonologist for adults working in Erasmus University Medical Center Rotterdam, which is my hospital. And I think it's quite special that Lieke talks in this session on congenital airway diseases, but Lieke has quite a lot of experience in treating adults with these kinds of diseases. And I'm really happy that she will talk about this and show us some results of adults with these congenital airway diseases. Lieke, the floor is yours.
Good evening, everybody. Thank you for the introduction, Marielle, and thank you for the invitation to speak here tonight. I'm a pulmonologist in Rotterdam, and the last part of the presentation will go about the view of the pulmonologist on congenital airway diseases. So why is it so important to know something about congenital airway diseases if you're a pulmonologist? The first reason is that it is increasingly diagnosed in adults, and I want to start with a few examples from our outpatient clinic. To start here, case 1 was a woman of 31 years old referred to our outpatient to our hospital 1 day after labor because of shortness of breath. And her lab results were showing an elevated level of didymer. So logically, the thought was that it could be due to a pulmonary embolism. So a CT scan was performed, but we did not see any pulmonary embolism, but we saw this cystic mass. And further analysis showed that this was a CPAM, where Marco just talked about. And she received a lobectomy. And the tissue samples showed a pre-stage of lung cancer. The second case was a boy of 19 years old, sent to our outpatient clinic with shortness of breath during exercises and frequent respiratory infections. His pectus excavatum was observed by his parents around the age of 4, but he had an X-ray which showed air trapping. After that, a CT scan was performed, which showed this, and we decided to perform a bronchoscopy. And there we saw a narrow entrance of the right middle lobe. And with that, together with the frequent respiratory infections, we decided to perform a lobectomy. And on this moment, he does not have any complaints. And the material showed that it was due to congenital lobar emphysema. Another example, case 3, a woman of 42 years old, sent by her general practitioner to our hospital because of also recurring respiratory infections. And her medical history showed that she was suffering from gastroesophageal reflux disease due to esophageal atresia. And because of her reflux, she got bronchiectasis, and we optimized her treatment for the bronchiectasis and sent her to the gastroenterologist to optimize her reflux treatment. And the last case I want to present was a boy of mid-20s, born at 26 weeks, after 26 weeks of pregnancy, and received weeks of oxygen treatment hereafter. I wrote it in italic because it's not a congenital disease, bronchopulmonary dysplasia, but it's a perinatal disease. But I want to mention it here because, like Maria told, we have a lot of experience in our center, and our center is not just only congenital, but also perinatal diseases. So coming back to this slide, I already mentioned it is important because it is increasingly diagnosed in adults, but also not much is known about the follow-up in adulthood. There are no protocols are rare when somebody reached the age of 17 years, and there are no large cohorts of congenital airway diseases in hospitals. So I decided to start a center in the Netherlands for congenital and perinatal airway diseases in 2018, and currently we are there working with 2 pulmonologists. And this is a center for a long-term follow-up for patients older than 17 years. We saw the first patient in June 2018, and nowadays we have more than 300 patients in our follow-up program. I want to pick out one of those diseases because we had an unexpected giant draw for patients with a congenital diaphragmatic hernia. So I want to focus the last part of this presentation on CDH. Some general information about CDH. It's a rare disease with prevalence 1 case per 2,500
Lieke, we have a problem with the sound. You are muted now, but it was a bit. Maybe you can try again.
Yeah, from this slide I have to start again?
Yes, please.
Yeah, okay. I want to start with some general information about CDH. It's a rare disease with a prevalence of 1 case per 2,500 live births, and mostly it is left-sided. CDH stems from an incomplete development of the septum transversum, and normally it separates between the 3rd and the 9th week of fetal life the body cavities. First, the right diaphragm is closing, and after that, 1 week later, the left one is closing. And that's also one of the reasons that most of the CDH patients have left-sided CDH. Most cases are presenting in the first 24 hours of life, and late diagnoses are rare, less than 3%, and the survival rate is around 60%. When you diagnose, now it doesn't work. When you diagnose somebody with CDH, surgical repair is needed, but most important, after the surgical repair, the biggest problem with the lungs is still the remaining lung hypoplasia. So I want to focus on the lung hypoplasia. Nowadays, the exact pathogenesis about lung hypoplasia and CDH is still not known. The most accepted one is as follows. The diaphragm is completed by week 9 of pregnancy, but if there's a persisting defect at week 10, then this leads to a transposition of the intestines to the thoracic cavity. Normally, lung development occurs between week 14 and 16 of pregnancy, but as you can see in this picture, there's no normal development of lungs when there is CDH. Lung hypoplasia is more severe on the side of the defect. The ipsilateral lung is small, has reduced size bronchi with less branching, arterial-medial wall thickness is increased, alveolar septa are thickened, and there is an abnormal development of the surfactant system. And furthermore, the loss of the continuous diaphragmatic muscle markedly impairs the fetal breathing movements that are necessary for a proper stretch-induced lung maturation. So if we see patients at our outpatient clinics, so adults with CDH, most of them have complaints of wheezing, shortness of breath, and coughing. If you go with those complaints, for example, to your general practitioner, a logical step will be to perform a pulmonary function test. Now, what we know of adults with CDH, most of the time they have persisting airway obstruction. Well, if the general practitioner gets this information, it will be logical to think this could be asthma or an asthma-like disease, and the next step will be often to start with an ECS. Now, what we see in our population is that ICS does not improve the clinical signs or the pulmonary function. So what we added to our follow-up program in adults with a CDH is a CT scan. Here you see an example of one of our patients, but this is what we mostly see in all of our patients. We see an emphysema-like pattern, and because of this, we thought we tried off-label to treat those patients with a labellema. And almost every patient showed improvement of their pulmonary function test and of their clinical signs. And here you see an example. This was a patient referred to our hospital for screening in September 2019. And here we started with the labellema. And after 2 months, you see an elevation of the FEV1 and the FFC after 2 months treatments. And you see it's also stable during the treatment. What I always mention to my patients, I'm not a doctor who treats numbers, I want to treat clinical signs. What makes it so difficult in this group is that those patients, they are born with those lungs, with these lungs. So there is no moment that suddenly they got shortness of breath or suddenly they're coughing. They're used to it. So what me and my colleague are doing is that we try a trial for 2 months to see if a labellema does something about your clinical signs. And I can mention that almost half of those patients, they're feeling a better lung condition, and we also see it back in an improvement of their lung function. Because we are adding a CT scan in our follow-up program, we also are getting more information about a relapse of the CDH. Here you see 3 examples of patients in our cohort with recurrence of the CDH, and 2 of them got a repair. I won't talk much about it because hopefully this year there will come a publication about it, but more than 40% of the patients has a recurrence after the age of 17 years. And the last 6 months we had a research with 2 patients and with 5 patients, and 2 of them are shown here. An important reason to reoperate is symptomatic versus asymptomatic. That's what I want to say about it, and all the other information will hopefully come later this year with our publication. Another big dilemma in this group are women who want to become pregnant. So far we had 4 pregnant women, 1 normal pregnancy, and 1 woman had during 20 weeks of pregnancy a release patch, and she needed a reoperation during her pregnancy. And 2 women had a preterm birth because of severe respiratory failure of the mother, and it was so dangerous that we decided the pregnancy could no longer couldn't be a day longer, so the baby was delivered early. So if you look to these numbers, then the risk for an abnormal pregnancy in women with CDH is 75%. So is it safe for CDH women to become pregnant, and what are the risks for CDH women? What we are doing also in our follow-up program is that we are performing a MIP-MAP measurement for all our patients, men and women. And the maximal inspiratory pressure, the MIP, and the maximal expiratory pressure, the MAP, there are global measurements of the maximal strength of respiratory muscles, and especially your diaphragm. If a woman has a worse outcome of these MIP-MAP measurements, you can imagine that during the pregnancy, your diaphragm will sooner elevate, resulting in earlier signs of shortness of breath. So should this measurement be a rule in making a decision if pregnancy is possible or not? Another discussion, coming back to a couple of slides earlier, should we reoperate women with a pregnancy wish before starting in pregnancy if there is a relapse? So these are dilemmas, and we hope to give all of you an answer after a couple of years when we will have more experience with this. So in conclusion, this was just a small part of what we have seen the last 3 years in Rotterdam, but we are there to say that congenital airway diseases in adults is, or at least should be, a new subspecialism for pulmonologists. Long-term follow-up is needed for patients and for doctors to learn more about the outcome of all those diseases, and especially at older age. In this presentation, I give you a few examples for dilemmas in CDH, for example, the recurrence in pregnancy. And I did not mention it now, but also a screening for pulmonary hypertension is recommended in adults with CDH. We see it around 10 to 15% in our group. Hopefully, I could convince you that CDH is just one of the congenital lung diseases which needs follow-up. But how we say it in Dutch, this is just the tip of the iceberg. We have lots more what we see in our cohort of 300 patients, but we can discuss about. I don't know if we have time left, but I want to end with a multiple choice question. But I don't know if you see it already. I already see the answer. Yeah, that's correct. The arterial medial wall thickness should not be decreased, but is increased in the pathogenesis of hypoplastic CDH lungs. Okay, this was my last slide. Thank you for your attention. And I will give the word back to Marielle and Carolina.
Thank you to all the speakers and the outstanding presentation. I learned too much today, and I like all the presentation and the cases. I would like to read some questions that in the chat. We have so many questions during the meeting, and I would like to start to Ernst, a colleague, tell us. As a pediatrician, I see many children referred with recurrent airways infection. Of course, this is a common problem, and often there is not an anatomical abnormality. Which signs or symptoms would you suggest that could raise the suspicion of the airway abnormality?
Yeah, as in many cases, airway anomalies cause airway obstruction. I would look for signs or symptoms of airway obstruction. So it's clearly respiratory noises. I would look for like inspiratory or expiratory or biphasic stridor, or wheezing, be it persistent noises or intermittent noises. I would also look for problems that are related to feeding of the child, for instance, just to say a few.
Thank you.
Thank you.
I think there are some questions for you, Marco, about the follow-up of the children with the congenital pulmonary abnormalities. Can you tell a little bit about the follow-up program you are following in a child who is asymptomatic? So when do you see the children? Do you imaging? When will you perform lung function testing?
Yes, I can, Marielle, thank you. Well, in Rotterdam, we have a standardized follow-up scheme of children with a congenital lung malformation. So if we know that prenatally a cystic lesion is diagnosed, we always perform on day 1 an X-ray just to see if there is a large shift or there's a large cystic lesion, and if that's not the case and the child is still asymptomatic, we just discharge the child. and see him back 4 weeks afterwards, just to see if the feeding goes well, if he grows, and if there are not any signs of respiratory distress. At the age of 6 months, we make a CT scan of the chest with contrast, just to confirm our diagnosis. It is known from our own series that about 3/4 of the patients who are antenatally diagnosed with a CPAM appear to be something else afterwards. So the CT scan at the age of 6 months is crucial, just to diagnose just to confirm what's the diagnosis. Afterwards, we see the children regularly at, for example, 1 year of age, 18 months, 2.5 years, 5 years. And at 5 years, we perform a bruise test. So that's the first time we really try to test the how do you call it, the
exercise tolerance.
Tolerance of the child. And at the age of 8 years, we perform a lung function test. Well, we just started with a transition protocol to, for example, refer the patients to the adult pulmonologist, to Lika, but it depends on if the children want to be referred, and if there are any complaints or symptoms.
And can you comment in a child who has been operated, do you think there's a need for a CT scan post-operatively?
Well, to be honest,
and if so, when?
Yeah, to be honest, we really don't know. It is known from literature that when you operate on a CPAM and you do not remove the entire lobe, you have a chance of about 50% of a recurrence. But we do not do a chest CT scan at a certain time, and now we just have to think about if it should be if it's necessary to do that.
Carolina, did you pick up other questions?
Thank you. Yes, I have another question about malignant. For all the speaker, CAM could be turned malignant in the future. Can you tell us any experience or data about that? Hello?
Yeah, I can. Can you hear me?
Yes, yeah. I can hear you.
I can start off if you want. I have both from the literature and also from my personal experience. I can tell you that you in a CPAM lesion you may have malignancy in the future. I've seen an adolescent child with bilateral malformations, and she developed bilateral carcinomas. And when you look at the literature, there was a very nice paper only 2 years ago from a United States group, which showed nicely that looking for these mucinous cell clusters, and they only found these mucinous cell clusters, which are said to be kind of possible precursors of malignancy in this type 1 CPAM and not in the other types. So I think it was a series of about 180 or so a large series of histologic specimens. So yes, there's definitely a chance to develop malignancy.
Well, if I can add to that, we looked in our series as well, and in our series we both looked at type 1 and type 2 CPAM children, and it were both groups of 25 patients. And we saw in both groups mucinous proliferations, and it appeared that all patients with a mucinous proliferations are KRAS positive as well. And we really don't know what it means, but our gut feeling says that might be the children at risk.
There was a question on that as well, Marco. Do you know anything about the incidence of KRAS mutations in the general population?
Yes.
No, I don't know. Sorry.
No.
About the last question, sorry, Maria. Another colleague asked about this adult patient who remains asymptomatic with a congenital airways disease malformation. Sorry, could there any time discharge of this patient, or still more developing malignant, still more prone for developing malignant in the lobe? We must do any tests routinely. I don't know, maybe see that this patient. Sorry, my internet connection is unstable. I don't know.
We lost you for a moment, Carolina. Can you repeat, please?
Sorry. Another colleague in the audience asked about these adults who remains asymptomatic with airways malformation, pulmonary airway malformation. Could there be any time point that you can discharge them, or are you still more prone for developing malignant in that lobe? So we see them every year, or every 2 years, or I don't know if I explain well.
Yeah, so I think that's a question for Lieke about the follow-up of CPAP patients in adulthood. How often would you follow them, and which investigations would you suggest?
Yes.
Yeah, on this moment we have 15 adults with CPAP in our cohort. And because in the literature it's not known if they can develop a new malignancy in their lungs, we are holding them in our outpatient clinic. Me and my colleague are performing CT scans every 3 years. But we have to see in the future if that is necessary, or if it could be a CT scan every 5 years. But currently we are not letting them go and holding them in our follow-up program.
And is there a role for MRI?
Yeah, there's always a discussion for pulmonologists versus the pediatrician. We are not used to perform MRIs in adults. I also I don't know if there is a difference between the catch on a CT scan for lung cancer, or if it's comparable, if you compare it with an MRI. So I have no idea, but nowadays we're still making CT scans. Yeah. And also what Marco told us about the KRS. Yeah, if we see in the future that you cannot develop a malignancy without KRS, maybe those patients don't need follow-up, and just the patient with the KRS need follow-up. But that's something what we still don't know. Nobody knows in the world, but hopefully we can, we can change the protocols after a couple of years.
Yeah, thank you. Maybe a question from my side. Do you have a special message for us pediatricians? Because you showed quite a lot of impressive abnormalities in adult patients with congenital hernia, but also with esophageal atresia. Do you have a message for us? Should we follow up these patients more carefully, more often? Should we do imaging when they are a child? And the other way around, do you have a message for your colleagues from adult medicine, how to follow these patients? Should that be in a university hospital? Is there also a place for the general pulmonologists?
Yeah, to start with your last question, on this moment we made a decision to collect all of the adult patients in our hospital to create a bigger cohort and to recognize patterns of clinical signs, patterns on CT scan, and hopefully after a couple of years we can find colleagues somewhere in the Netherlands or somewhere in Europe who is also performing the same follow-up program as we are doing. To start with the esophageal atresia, we see a lot of patients of them. I think we saw almost 100 patients, adults with esophageal atresia. And what we see is sometimes we see bronchiectasis and severe bronchiectasis. And in the follow-up program, there is no standard CT scan or MRI, just X-rays are performed. And we think that if there would be a CT scan earlier, for example, around the age of 16. Because most patients who we see now are older than 30 years, but if you perform a CT scan earlier in life, that you can, that the damage won't be so much as we see it now. That's for the esophageal atresia. For the CDH group, it mostly is that when they're 17, 18 years old, they're sent to their general practitioner with complaints, and the doctor says it's asthma. We see them back now when they're 30, 40, 50 years old, and we are telling them something what's completely new for them. Most of them, they even did not know that they had the CDH. I saw also a question from Suzanne Terbregge about leibalema, and if we tried it without, with a placebo, we did not try it, but we tried also it with ICS, and with an ICS, we did not see any change in the lung condition and in the pulmonary function test, but we did not try it with a placebo. But I also think for the CDH group, there's a big missed opportunity to what you can make in this group.
To improve outcomes, yeah. Well, thank you. Carolina, any questions from your side?
I have too many questions. It's many people asking about malignancy. I have a question. I think is for Lick. What could the best management for asymptomatic children with a prenatal diagnosis or CPAM? And what is the best timing to perform lung function and lung imaging? Thank you.
You mean in children, a lung function?
Yes, lung function and lung imaging. Sorry, I have an echo thing.
I think lung function won't say much. The most important thing is imaging. But a lot depends what we are looking now for the KRAS mutation, if it's there or if it's not there. Well, in this moment, we are following up our patient who did not receive research or did not receive surgery with imaging to see if it could be developed to a malignancy.
Well, thank you for your answer. Thank you so much, Lieke. I think there is a lot of space for new studies, especially in this group of patients where we don't know a lot about how they behave in adulthood, all those abnormalities. There are quite some suggestions for research from Peter Merkes. Can we maybe look at exhaled breath to see if they develop a cancer, RCT on LAMA versus placebo? So I think it's really, really nice. I'd like to thank you as the speakers. I think we had some excellent presentations. You made a lot of awareness, Lieke, about the long-term consequences of these abnormalities we see in childhood. I would like to thank Lieke, Marco for his very nice presentation, and Ernst for his excellent overview of these abnormalities in childhood. I would like to thank Carolina as my co-chair and the people from the ERS office, but in particular, I would like to thank the audience for asking all those questions and for attending this webinar. So thank you very much. Have a nice evening.
Thank you very much. Bye. Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.